Good evening, everyone, and thank you for joining us at Northern Arizona Orthopaedics. Tonight, we have a very anticipated lecture titled All About Sciatica and the Treatments for It. Before we get started, I would love to share with you a quick tip on how to engage with us throughout this presentation. So we expect many of you are going to have some questions. Please submit them using the Q&A feature at the bottom of your screen. And feel free to submit them during this presentation. We will go ahead and compile them as best we can for after the final session, and we'll answer them at the end of the seminar and spend about 15-20 minutes doing that. And now it is my pleasure to introduce our new physician here at Northern Arizona Orthopaedics, Dr. Michael Sorensen. Dr. Sorensen is a board-certified physiatrist specializing in physical medicine and rehabilitation, as well as interventional spine and pain. Dr. Sorensen is an expert in non-surgical treatment for spine conditions. And with that, let's go ahead and get started. Please begin, Dr. Sorensen.
All right. Well, good evening, Arizona. So happy to be here. So welcome everyone, spending your time learning a little bit about sciatica tonight. Thank you. So our talk all about sciatica and treatments for it. My mouse working here?
Go ahead and pull it
We
up.
are, okay. And we want to go to the next slide. So I'd like to give a bit of thanks and appreciation to the Spine Intervention Society for some of the slides, and Clinical Anatomy, Dr. Bogdut, for his expert research on lumbar anatomy. So what is sciatica? So the definition of sciatica, if you look it up in the dictionary, it's pain along the course of the sciatic nerve. Looking at our diagram, the sciatic nerve comes down around your buttock. It can be pain in the buttock, especially towards the back of the thigh. Or another definition, pain or abnormal sensations in the lower back buttocks and down the leg. And typically, it is one side more than the other. So actually, what is sciatica? It's a symptom rather than a specific diagnosis, even though it may apply, or rather may imply certain diagnoses. It's been actually described back since 1764 by an Italian anatomist. So for most clinicians, it would refer to a radiculopathy, and that's a term for a pinched nerve in the low back. So, and that can radiate down the buttock and the legs. More often than not, it involves one of the legs rather than both, but it can do both, and typically caused by a herniated or ruptured disc. So, however, patients and many clinicians talk about low back pain that aches in the buttocks and can go from the buttocks into the leg as sciatica, where much of the time actually it's referred from the low back, meaning it starts from the low back and it aches into the buttocks and extends into the leg at times when it's not actually a true pinched nerve or disc herniation. So sciatica can be rather confusing and ambiguous. So I'd like to go over some of the pertinent spine anatomy. So looking at the spine, there's the anterior or the view from the front, the very far left, which we usually don't look that direction that much on the spine. So looking up here, let's look at the next one. So this is the side or lateral view. When we look at the cervical spine or the neck, the 12 segments or thoracic spine and the 5 lumbar segments, and then we have our sacrum and the coccyx. This is the posterior view or the view from the back of the back. Just to give some perspective, there's a lot of complicated layers of muscles and tough ligaments attaching. This is the spinous processes where they're attached. When you lean over, you can have these bumps that we'll see in the spine anatomy models. For example, here is a zoom in for the lower back, which is the lumbar spine. So this is a side view or lateral view where we have the vertebral bones, and between them, the cushions of the discs at each of the levels. And as you note here, these openings are where the nerves come out each side, and the central canal is behind here. The cross-sectional view of a typical lumbar vertebrae looks like this. And to describe how it weight bears, there's the bone. Think about a tricycle. If you're sitting on a trike, you have the big wheel in the front, and then the disc is between. So the weight goes on the disc between the bones in the layers. And then I say you'd be sitting, I guess, in the spinal canal right there. And then you have that joint right there, the facet joints. They're like knuckle joints on your hand. So the weight bearing and degeneration over time can occur in the disc between the bones, the big wheel in the front of the trike and the two back wheels. This is the posterior back view. These are these spinous processes that when you bend over you see, as I mentioned. And here's the facet joint on the left at this one and the facet joint right here. And that's pertinent because the disc can be a painful structure and rupture and pinch on a nerve and cause sciatica. The facet joints can cause pain in the back, but they can ache in the butt and down the leg also without pinching a nerve and cause the back, buttock, and leg pain that you could call sciatica, but not from a pinched nerve. So here's the spine X-ray AP, which is basically a front to back view. You have 1, 2, 3, 4, 5 lumbar segments right here. And as we look a little more detail than you might want, but the important findings that we're talking about is the disc. Just mentioned the cushion intervertebral disc. So with regular X-rays, you don't actually see the disc. You refer to the disc space, and you have a normal disc space, just like in a knee. You could see a knee X-ray and you have a joint space, and if it gets degenerated, you might have a narrow space. Well, the same as with the disc cartilage cushion in the back. And this is the vertebral body, each of the 5 here, and this is the lumbar 5 here. It's counted 1, 2, 3, 4, 5. And when we look into the next, the sacrum comes below the lumbar, and these don't have the discs between them. And this is the wing bone of the pelvis called the ilium. So the joint between them is called the SI joint, the sacroiliac joint. And that can be pertinent for pain in the buttock and can radiate down the leg also. And here we are with our lateral view, the side view of the lumbar. And I'll go, and we talked about this in the other slide. I'll go to the slide here where it talks about the pertinent structures. So here's the vertebral body bone, and there's the disc space, because we can't see the actual disc, and these are looking pretty normal here. And this is the normal curve called the lordosis or sway back curve of your low back when you look from the side. That's normal. And this is the L5 and the S1, the sacrum, first sacrum, where there are fused segments. When we take a look at the sacroiliac joint again with a diagram, so here's magnified the ilium or the pelvis bone, kind of the wing bone, and then you have the sacrum. We'll look at the magnified. Here's the hip bone, and it's not the ball and socket. So it's not the ball and socket hip bone, the femur, the leg bone into the ball and socket. We're talking about the wing bone that's up on the, basically looking like that. The joint is called the sacroiliac joint, very close to the sciatic nerve, where we get the term sciatica. So these are the imaging correlates where we look at the human specimen to the lumbar MRI. This is the side view called the sagittal, and it's mid, so it's right smack down the middle. So these are cross sections of the vertebral body bones, and here's the disc. The disc has a nucleus, like a cell. We have the center as a nucleus. And a fresh nucleus that's not degenerated it looks like crab meat. It's white and glistening and spongy, and you couldn't have your whole disc that way because all that weight, you'd smush it right out. So this is called the annulus. So it has rings like an onion, or maybe rings like a tire belt. So it's really tough. And then with all that weight, it won't squish out this to the side unless it gets degenerated and torn and you have a ruptured disc, which we'll talk about, which can cause sciatica. This is the central canal from the side that has the nerve roots going through, or the cauda equina, the other term. These are the spinous process bones from the cross section that it's the side view, but it's sectioning the spinous processes, the bones in the back when you bend over that I mentioned. You see in the mid back. This is the this is the disc, and this particular MRI image has the water or the spinal fluid very bright white, and you can see, not super clearly, but you can see the nerve roots or cauda equina descend in that fluid. There's no narrowing, the nerves are happy there. And if you look around the disc, on each normal disc it doesn't have a hydration. The center disc, which is like the crab meat, is very squishy, And then here's the tough annulus that keeps that in. And these look normal, corresponding to the structures to the left here. Now, off center, right and left side, you have the disc and the vertebral bone looking similarly, but on each side, right and left, you have the nerve root exit. And normally the disc is flush with the bone and there's space and epidural fat around it, so it's happy. It has plenty of space there. It's not being pinched. So that level looks like that, level looks like that, and it's not a perfect section for that level. So that's not a defect. It's just not all in the same plane. Looking over on that, this is the nerve root and the space around it, and there's the disc again and the vertebral bone. And here's a cross section or the sagittal view. So again, here's that nucleus. This is really big and enlarged. This is the nucleus, the center that has the squishy cartilage, and this is like the radial belts or the belts or onion rings, that tough cartilage that tries to keep that in. Here's the center canal with the nerves going down, up and down the spine, spinal canal, and there's got lots of room for fluid. There's nothing being pinched. When we're looking at the MRI version of the cross section or axial view, you might notice that here's the central canal, has lots of room. The dots are the nerves, and the water, the spinal fluid is bright white. Where this one, the spinal fluid is dark. It's just the way the MRI with that particular cut called a T1. Just different ways that we can look at things. Looking at the side or lateral view of a lumbar, where you have the normal curve, this is something that's also a defect that can potentially pinch on the nerve in the spinal canal, called a Spondylolisthesis, kind of a fancy word, or a slit, where even though there's a bit of a curve, they're all lined up except here, there's a jig jog right here. So this should be lined up and back here, and this should basically be that distance. So it causes a little kink in the canal, and it may pinch the nerves. And we can talk about that. Here's the side view. These facet joints, remember the little joints that are like the back wheels of a trike, the right and left? You can get just kind of a sense this whole area is thicker and arthritic compared to the size of these joints, just for comparison here. It's a little more subtle. This is our sagittal side view of the lumbar, where you see the good hydration in the discs. And this is one which is not really narrowed or degenerative, but it has desiccation. So it has dehydration, or you can desiccate fruit. You have a food desiccator rather. So the nucleus loses the water content. That's a common earlier change of a disc, and it's barely bulged, so it's mildly degenerated. This one is more than that. This is actually ruptured or disc herniation here. And you can see the difference. It's not impinging or pinching any of the nerves coming down the canals, but this one, it's causing what potential pinch that with pressure and inflammation can cause the sciatica. Coming back to that slide where the diagram, the exit zone on each side, we said the nerves come out in an orderly fashion, and the lower lumbar turns into the sciatic nerve. Actually, the upper lumbar turns into the femoral nerve in the front. So that's a little more detail there. But that also can pinch a nerve and ache in a different part of the thigh. So when we look at sciatica, you can say, is it actually radicular pain, the pain from the pinched nerve in the back, which it is most of the time for classic sciatica, or is it actually caused from a pinch of the sciatic nerve itself? Or is it actually referred pain? So structures in the back or buttock or sacroiliac joint can ache, but cause pain referring down. Referred pain, for example, if you look at, or not look at, but if you think about heart pain, you can have a shoulder pain from your shoulder hurting, but what's kind of a classic referred pain from a heart? When you get a heart attack, why does your shoulder hurt? Well, why does it? It's referred pain. It's fairly complicated. The neural pathways that come up from the peripheral from down below, get into the spinal area and in the brain. And so it kind of tricks the brain a little bit. The pathways overlap. So there's a referred. It's kind of complicated beyond our talk, but referred pain basically is pain away from the main pain generator, or the main source of the pain. Here's our diagram of a herniated disc. Say that 10 times, herniated disc, where this diagram shows that crab meat type consistency. It's not gel. Some people say it's like a gel. It's not a Bismarck donut. It's not that kind of gel. And the more dehydrated and degenerated, it gets a little tougher. But you have like a blowout. So those onion rings or those radial tire rings around the annulus that should keep it for how many years. It keeps it from getting squished out, commonly with degeneration, or it can be a combination of degeneration with injury, like a bending, twisting, lifting injury, where it just is too much for the disc and it ruptures out. This is the enlarged view where there's a physical pressure on the nerve, but it's more than pressure. Anytime you have a herniated disc, there's inflammatory chemicals, just like if you cause an injury of numerous areas of the body, you might get all the inflammatory cells and chemicals, and if it's by a nerve, it causes irritation, and if it's one of these nerves, it goes down the leg and causes sciatica. So these are some fancy terms. Radicular pain, I mentioned before, that pertains to the pinched nerve in the spine. And when we talk about the pain, or radiculitis, is the inflammation of the spinal nerve root, and radiculopathy goes another step further rather. It's a dysfunction from the compression or inflammation. So going a bit further, the radicular pain is a nerve pain. It can be sharp, it can be burning, it can be electric, and it can be localized to the nerve distribution that fits that nerve, but not always. There's always variations and exceptions where it's not perfect. We'll talk about that. Radiculopathy implies, though, goes beyond the pain, implies weakness. So you can have weakness of muscles of your leg. You can have numbness of the skin rather than just sort of a sensation, or you can have funny sensation and the numbness. And you might have, depending on the nerve, you might have a reflex. A reflex is where you're sitting, the doctor hits you on your knee and you kick. That's the patellar or the knee reflex, for example. Coming back to that MRI scan, this is one where we have some degenerated disc. This is pretty normal. You see the hydration in that with this image where the fluid is white, the T2, and this is a little degenerated. But take the attention to here is a big herniation or extrusion, which can narrow this canal. It's a bit of a bottleneck where these nerves come down and creates pressure plus inflammation. We'll look at that cross section right through here as we look along here. So this should be oval or round, and this is the nerves more on this side. Actually, the way these cross-section views are, this would be a sort of left of the picture, but if you look up from the patient's feet up towards his head, is the convention that they always would do CTs and MRIs. This is actually the right side of the body. So this is a protrusion on the right side. If we look up here as well. So this big hunk of disc is taking a big section of the spinal canal right here. And that particular lower disc would pinch the S1 nerve. And this is a representation from the buttock down the leg, usually the side, and down towards the side of the foot for the S1 nerve. Now there's different strips. I think they're representing that you might get the main strip of pain or numbness or tingling and some variations of that. If you were very astute when we were talking about the sides, that herniated disc was actually on the right side. So this wouldn't be the exact, it would be on the other, the herniated in the prior slide. But the left side would cause this down the two little toes on that towards the bottom of the foot, more towards the back. That's a typical S1 distribution from the disc herniation. That's at L5, S1. And looking here, this is at L5. This is on the other side. This is actually the left side off center, but also this is the exit zone or the neuroforamen where it's pinching exit zone. So when we looked at the samples of earlier in the anatomy where we have the small nerve coming out at each of these levels, we can see that nerve with all of its space around it, has plenty of room, but something's different here. This fat around that nerve, that space, you can't even see. The fat's pushed aside. This nerve is being pushed in this exit zone neuroforamen. So that would be very likely that the L5 nerve would be pinched and painful, and maybe there'd be weakness. And maybe be radicular pain and radiculitis. This is called a dermatome map. So this is a skin map of different nerves. So here we looked at, it's a little hard to see this one. The S1 is off to the side, and then the L5 is more towards the top of that foot. Here's the S1, the pink on that side. And frankly, if you pinch some of the upper ones, like an L3 goes more here. So it might hurt in your low back and start in your butt, but it'll start wrapping around the front if it's an L3, or way up high at L2. Actually, an L2 is hurt you in the groin, and that you might even think there could be hip pain. So as I mentioned before, it's not just physical pressure from a ruptured disc or a bone spur pinching on the nerve. So when you have a herniated disc, or even a tear of the annular, those fibers that I described were like the onion rings, it causes inflammatory chemicals. And so if it's by the nerve root, it can cause the nerve dysfunction and pain, even if it's not causing a lot of pressure, or both. This is the diagram where we have the nucleus, and there's a tear. It's not really, frankly, herniated right here, but it's a tear. When we look at the MRI scan, it would be, you could say it's a bulge or really small herniation, but it's a white spot. So there's a, in this image where we talked about the desiccation or the dehydration of this disc, finding my, there we go, finding my, gotta find my mouse again, I apologize, there we go. There it is. So this is a normal disc. Here's the desiccation or the drying out. You don't see the water signal in the disc, but you see a very high signal here. Actually, HIZ is hyperintense zone. It's high intensity, meaning it's an area that correlates with inflammation and correlates with pain. This is more in the center, not so close to the nerves on the side here. But if, depending on where this tear is, it can cause the inflammatory process and give you this radicular pain. That's irritation of the nerve of the back, which can cause your sciatica. Here's another thing that we're going to talk about. Spinal stenosis is somewhat different. When we look at your spine, the central canal is behind you. Here's the exit zone, but the central canal goes through here. And when we look at, here's the disc again, there's the nucleus. These are the facet joints. Remember that little trike where there's the big wheel, there's the two little wheels here. And there's the central canal where it's more or less round or oval, and it has the fluid and the nerves are in there, and that's more or less normal on that. As people age, you can get bulging disc. It may not necessarily be a herniated disc, but it can be bulging. And these joints here, these are about the size of knuckle joints on your hand. Everyone's seen or has, depending how old they are, knobby knuckles in the hand. They may or may not be painful themselves, but when you have bone spurs or knobby knuckles of the facet joints, it doesn't really do much out here. They might have pain of the joints themselves, but it's taking a bit of that canal. It's taking a little bit of that space on that side. It takes a space on that side in the disc bulge. So instead of a nice canal, we're getting a narrow, compressed spine canal. So when we're looking at fairly normal looking spinal canal and the nerves are going down, there's plenty of room, plenty of fluid, plenty of space. This one has multiple levels of degenerative discs and herniations and spurs, and this would be the facet joints from behind. Basically, it's showing a kinked spine. As you see, there's a bottleneck there. There's no bottleneck here. There's bottleneck at multiple levels, causing stenosis or narrowing. So it should be, your spine should look like that, and it narrows down. When we look at the MRI again, so here's a normal canal, round or oval. And this one's a bit dark, but because of this facet joints and then some ligament thickening, it's taken off that corner. The other one's taken off that corner. The bulge is taken that. So instead of round, it's a triangle. So the nerves are all bunched together. There's barely any fluid around that. And that usually mechanically, if you stand and walk, that gets even narrower. So that's when people with stenosis get even more symptoms. When you sit, it opens it up just a little bit more, just enough to get by. So here's the comparison. We saw that slide. It has lots of space. Here's the one with stenosis, that little triangle. So the nerves are all bunched up. So this is a little different here. Here's a little degenerated disc. These are fairly normal, but this is a fairly good sized disc herniation right here. A little degeneration from behind and thick ligaments, but this is stenosis at that one level mainly because it's a very big herniated disc. So as you can see, these descending nerves are a little kinked, and this is the bottleneck. So here's a disc herniation causing stenosis right here. So this patient didn't respond to the conservative care and injections, et cetera, and they had to get surgery to open this up at that level. There's another aspect that you can have spinal stenosis called a facet cyst. Perhaps people have seen a synovial cyst of a wrist or a finger where that cystic from the joint and a fluid-filled cyst. And you can get fluid in the facet joint, and you could have a cyst on the outside. But when the cyst, fluid-filled cyst, is on the inside of your spinal canal, that's not a disc herniation or bone spur. That's a cyst that's taking up a good hunk of that and causing stenosis. So I can aspirate those, and it works sometimes. or sometimes you need the decompression surgery, which we can discuss later too. So we've talked about the more classic sciatic cause from the pinched nerve in the back, from the nerve root. No, actually, could we go back one? I'm sorry. The nerve root out of the back, which would be represented here, or the actual sciatic nerve. Sciatica can be caused in fairly rare percentage from the sciatic nerve. This is called a piriformis muscle right here. Sometimes there's a reason why that you can have pressure over this area from sitting. We'll talk about that. Here's the diagram of the muscles, the gluteus, the buttock, and all of the complex muscles, including this muscle is the piriformis, and the sciatic nerve is underneath here. Very complex muscles. The white is the ligaments or the tendons attaching to the bones. Here's an easier diagram talking about the piriformis syndrome. Classically, as if the piriformis muscle is tight or there's an abnormality that can pinch the sciatic nerve, so it's not actually from a pinched nerve in the back. So one particular study referenced here said that the compression of the sciatic nerve was up to 6%. I've seen it very rare, so it's even very low percentage, maybe up as high as that. And there's two types. So primarily due to the piriformis, if there's an anatomic cause, there's a split in the piriformis, so the sciatic nerve goes through and is pinched, or there's a variation in the sciatic nerve itself. So that's fewer than 15% of an already small number. Or it can be secondary piriformis from different trauma. I'll put this next slide describes that. Macro trauma, so if you have a blunt trauma or something where you get hit hard in the buttock, and a hematoma is a big blood pocket that could push on the sciatic nerve. You could have an injection. Somebody could do some type of an injection where they want to get in the buttock muscle and they could stick the sciatic nerve and cause damage. You can have scarring affecting that nerve. That's macro, meaning big. Micro, meaning small, more microscopic. Overuse of the piriformis muscle, like long distance walking, running. Direct compression, like prolonged sitting on a wallet syndrome. Those have been described. Ischemia is a fancy term for reduced blood flow, and that could be mass effect maybe from compression, etc. So getting back to our third cause, we talked about sciatica, where it can be from the pinched nerve in the back. It can be the sciatic nerve more rarely, but actually commonly you can have the referred pain, a structure in the low back that aches in your buttock, and it can refer into the leg, even though the pain generator, as we say, the source of the pain is in the back. So here, piriformis is a muscle. Now, these are called trigger points or tender points or trigger points. They're more trigger points tend to refer. So this is not piriformis syndrome pinching the sciatic nerve. This is just piriformis muscle that causes aching that looks like a sciatica. It's aching down the back of the leg. And actually the other muscles, there's all kinds of, the gluteus maximus, the gluteus medius and minimus, the other muscles that are not shown here, they can refer down in the thigh and the leg also. So here we have muscle pain that can refer down the leg that is causing the sciatica-like symptoms. Oh, I'm sorry, I did a double hit. I beg your pardon, everyone. So when we look at common causes of low back pain, it's pertinent in the sciatica talk because it can refer pain and mimic that you might think it's going down the buttock and leg. So intervertebral disc, well, we were talking about that disc, the nucleus and all, can cause, even if it's not herniated, you can have disc pain as a big percentage of pain, 39, 40% approximately. Facet joints, when people are young, that's not as big of a percentage of pain. Old is a fairly big percentage of pain, maybe approaching what the discs are. Remember that slide with the stenosis where I showed the facet joints, like little knuckle joints that are arthritic. When people get older, they get more arthritic joints for facets, and that can cause pain. And the sacroiliac joint can cause pain. All of these can refer down and make it look like you're having sciatica. Now, if it's pain in your buttock, it usually is referred from lumbosacral. I have many patients come in and say, I hurt in my hip. You say, where in your hip? And they say, right here in the joint. And they point to their buttock. And I say, well, that probably isn't the hip joint. That's probably, if you think of it this way, put your hip in, or rather put your hand in your back pocket. And if you're hurting in the butt, it's lumbosacral is probably causing that. If you put your hip, hand in your front pocket, that's probably hip joint pain. hip joint pain can radiate in the front of the leg, and what we've been talking about for the lecture is lumbosacral pain can go down the back or stay in the buttock. And by the way, if you have pain in the side, it can be bursal pain, and it can be local, but it can actually radiate down the side of the leg. So here's a diagram. Oh, I did it again. I'm happy on this trigger. Sorry about that. I'm a lefty. I'm a righty, but I'm doing lefty everyone. So I'm not so ambidextrous. So this would represent front pocket pain. This hip joint is very common. And hip pain can radiate in the leg for people that are getting close to hip replacement. It can go along here, but the nerves in the back, like the L3 nerve, can be kind of close to that, L2 nerve or L3. When we look in the back, lumbosacral, if it's in your back pocket, it's probably coming from your back or sacroiliac joint. When it goes further, then you're thinking, well, great. The further it goes down the leg, especially below the knee, or it's more likely the sciatica, true sciatica with nerve pain. There's the side pain, the bursa, but that can radiate. Here's the bursa in a bigger picture, the iliotibial band. This bursa pain can hurt right there, hurt when you lie on it, but commonly it can radiate down the side of your leg, and that's not pinching any nerve at all, that's radiating pain. Here's the lumbar facet joints, where it can give you just back pain. Again, the lumbar facets are the little joints we said are like the back wheels of the trike that get degenerated. So you can have the facet joints ache in the back and radiate down into their leg, even quite a long ways down, without actually pinching a nerve. Sacroiliac pain between the sacrum and the ilium, that's pretty much where the joint is, and that's a very common spot for it. But sacroiliac can also refer pain, like sciatica. This is kind of a complex. Let's look at A. When we look at A, here's the sacroiliac, and it can radiate most commonly this way. Now, if you look at B, just to show you what that is, it's the same as A right here. It can radiate into the buttock. And then if you look from the front views, because looking from the back and the buttock, this is the left side, the left sacroiliac joint. And when I'm going over here in the front view, this is the left groin. So here's actually front pocket. A sacroiliac joint can mimic a hip joint and a back together. It's bothering the person in the back as well as in the groin. So that's something that's special about that joint. Or you could have a differential diagnosis. You could be having lumbosacral pain and you could be having hip joint pain. These other ones, number C is just showing it can be basically in the sacroiliac and radiate a little more in the buttock. The same thing there, and then you can maybe get that groin referral too. So it can be variable. But the main thing the sacroiliac is that it can radiate. I'm having a little trouble with that mouse.
Move it all.
Yeah, there we are. And I'm pushing. Yeah, now I'm actually having a hard time advancing. Here we go. Yeah, I saw it. Sorry, everyone. Having mouse dysfunction or user error, left-handed error.
Pull it all the way around.
All right, there we go. So there's my mouse. It's working, and we were talking about sacroiliac. This is kind of the classic one, and I'm trying to advance. There we go. Probably user error. I'll take full responsibility for messing up Carrie's mouse. So other leg pain. So basically, this isn't really sciatica, but when you're looking at somebody with sciatica, they might have a little back pain, but then they're having nerve pain in the leg. We have to realize that all nerve pain in the leg isn't coming from the back. I mean, we might have that from a peripheral nerve. In other words, the nerve in the leg can have some lesion. Not that likely. I mean, it could have a mass, but neuritis. It can be inflamed. Peripheral neuropathy is very common, especially in diabetes. Actually, these kind of peripheral nerve lesions common in diabetes too, but especially peripheral neuropathy. Peripheral means away from the body, and I'll show you a diagram in a second, that you start getting numb feet. And when your feet get numb, they start to come up higher, and then you start getting numb fingers. Vascular disease, vascular claudication is when you walk and you're starting to get pain down the legs and in the calves, and it's from a clogged artery rather than pinched in the back. But that is different from neurogenic claudication, the fancy term from spinal stenosis, causing really kind of similar symptoms. Or the referred pain, again, muscles, ligament, referred from the back, or I mean, you certainly might have the hip or the knee or the other joint or ligaments causing that. This is a diagram different than the dermatome with the nerve roots of the back. This shows different nerves where there's the femoral nerve right here, for example. If you have an L3 pinch in the back, it can do that. But if you have a diabetic femoral neuropathy, which can just happen, you can have that numbness in the thigh from that neuropathy or the neuritis. So we're looking at a differential diagnosis of why you're having leg pain. Is it sciatica, or because they might have back pain too and numbing? We have to really carefully evaluate and make a determination what's causing what. This is the classic neuropathy here, where we have, the mouse goes away, where you have starting in the feet and working up, and it gets bad enough it's hands, or you might just have it just in the feet. Proximal, this is much less common, where proximal meaning is close to the body, or you can have mononeuropathy, like a single nerve, or you can have compression palsies and neuropathies in the leg. And I talked about the femoral nerve a moment ago. This is the median nerve, carpal tunnel, and ulnar nerve. These are very common, but of course that's getting away from sciatica for the low back. But at least what I'm trying to explain though is that you can have pinched nerves causing pain in the back, or you can having disease of the nerves that's causing the pain and numbness in the leg. So where do we go from here? I think that was a trip a while ago. That's a Porta Vallarta, I think. So when evaluates the patient, it is an art and science. Accurate diagnosis is very important to get the best treatment. And the best treatment for sciatica, or what's causing it. Remember, sciatica is more of a description, not the diagnosis. So in a evaluation by the doctor, a careful history. A history is what the patient tells what's going on. You have to say what's important for this kind of a sciatica. What's the distribution? Is it just the back and butt, or does it go right straight down all the way to the ankle, or does it wrap around the side of the lower leg and do the top of the foot to the big toe? That's like perfect for L5 nerve. Or does it not have pain below the knee? Is there numbness or tingling or weakness? That's all important to know. Certainly if you have that, you're thinking if it's truly a nerve. And what triggers? Does it actually bother you from bending? Or does it bother you walking? Or is walking better and sitting bother you? So all of these are important to try to get an idea what's the cause of the pain and what's the diagnosis. So with a physical exam, we will look at, beg your pardon, physical exam. We look at the range of motion of the back. What are the movement patterns? Straight leg raise, we look at if there's a irritation of the nerve that's bringing one's leg up. The doctor does that in sitting or lying down. Palpation is the doctor pushing. Basically, is there tenderness? Where is the pattern of the tenderness? And are there neurologic findings? Even though you might have some tingling, is it actually a bit numb? Are you weak? And which muscles are weak? Are the reflexes normal or not? Are you having normal gait? Are you walking with good coordination or not? So all of these can be very important. And the way patients present is the way, in other words, the way they give the story, the way the exam, the distribution of where the pain is. Some are classic. I mentioned a moment ago, somebody lifts something, they get back pain, then it goes down their butt, then it goes around towards the side of their lower leg and wraps around to the top of the foot to the big toe, and it's numb and tingly. You might have a little numbness when they're trying to walk up on the heels. I mean, that's classic. That's L5. The person tells you that, you know exactly what happened. But more often than not, all of the boxes aren't checked. When I think of the boxes, it's encyclopedia, you know, classic, like check, it's got check, 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 it's got all of that, you know exactly what's going on. More often than not, it's a little ambiguous. Or to make it ambiguous, it's mixed diagnosis. You might have the neuropathy, you get the numbness of your feet. It might be more on one side. You might be having referred pain. It's not actually true nerve. So it's a little of this and a little of that. It can be complicated. And that's what we're here for. Now, if there are warning signs that might be urgent or even emergent conditions. So if you're having sciatica, bad pain, and there's trauma, or you fell off a ladder, there's something you're lifted, it's a car wreck, something, you know, significantly, you want to make sure there's not bleeding in the spine or something, you know, bad trauma, not trivial trauma. If there is significant or progressive neurologic deficit, meaning if you have weakness, you have a drop foot and it's just getting worse, or you're buckling on, and so it's weak to begin with and it's getting weaker. That's something that can be urgent. That calls for an urgent evaluation, which likely is urgent scan and maybe surgery. One of the few true emergencies, bowel or bladder dysfunction. If you're pinching your spinal canal, which can give you sciatica and give you nerve pain, and if it pinches the nerves that are descending that control the bladder, so you have dysfunction, incontinence, accidents due to that. Cauda equina syndrome, the nerves in the spine are called cauda equina, the horse's tail. That's actually a medical emergency where you're looking at an urgent scan and urgent surgery. So something slightly different, if you have general symptoms, you've been having the sciatica, you're having pain, you're having fevers and chills and sweats, you're having a weight loss, you might be looking, do you have a cancer, do you have a mass, do you have an infection? I mean, these are very important things that we have to evaluate. You might have widespread joint swelling rather. Are you having something like a rheumatologic condition, like a rheumatoid arthritis? The next, progressive pain despite treatment. So whether it's not responding or if it's actually progressing and then causing these neurologic problems, we're worried about it. So definitely get into the doctor and get into us to check any of these out. And you have to look at clinical correlation when you look at a scan. It might have some people that say, well, look, let me show you this guy's MRI, and it has, a bulge here and a protrusion, and say, so what? What are the symptoms? It doesn't tell me anything. The MRI and X-ray findings may not be symptomatic. When you get older, you get arthritis and you get degenerative worn out discs. It might not correlate. You can have a herniated disc and it might not even be symptomatic. So you need to correlate the history and exam, the patient's sensation, what is going on with the patient in exam to the imaging studies. Electrodiagnostic testing is something I also do that might be a tiebreaker to determine, do you have nerve dysfunction? If you're looking at a neuropathy or a carpal tunnel, et cetera, we're looking at tests. Or if the scan is ambiguous, we're looking at that. This is kind of a tiebreaker. This is a study where you look at MRIs in asymptomatic people. People without symptoms, they studied and just did MRIs. So if you look at a disc bulge in different years, as you get up in ages, when you get to 50 to 59 years, 82% of people have bulges. So when people said, gosh, I went to the doc and they told me I had a disc bulge, it's like, well, you're 55 years old. It's like, so what? I guess the question is, does your back hurt or not? And does it even pertain? Now with disc herniation, H&P is herniated nucleus pulposus. So that's the fancy term. So that inner nucleus I talked about, the crab meat, that's kind of the medical term. You might see a herniated nucleus pulposus. The herniated disc, so asymptomatically, do the research study over 60 years, 20%, actually younger people where there's more hydration in the disc, it's 30% can have a disc that's not even symptomatic, a disc herniation. So if you do have the sciatica, the nerve impingement, again, sciatica most is common, pinched nerve in the back, usually 6 to 8 weeks can be conservative care unless there's the danger signs that we talked about. Progressive weakness, severe weakness, cauda equina, bowel or bladder, which of course that's very rare. So for the typical person that has the pain, maybe even a little bit of neurologic dysfunction, medications. And of course we have to look at, as people get older, I mean, they're on blood thinners, they have diabetes, so we have to look at what medicines might work for them and that are tolerated and won't cause other problems. So the medical history is very important as people have other medical problems. Posture and body mechanics and the physical therapy is very important. There are certain movement patterns that certain diagnoses do better with and actually get pain improved, whereas the same exercises with some other condition that might make them worse and vice versa. So traction is basically stretching. Traction doesn't work as well for the low back as for the neck, but that can be tried sometimes. Various exercises. Now, epidural steroids is putting cortisone in the epidural space, is the area around the sac where the nerves are. We showed you the sac with the fluid. If you put epidural cortisone, epidural is when ladies have a baby and put epidural late. They put a bunch of numbing in there and that numbs them all up. They put a lot of numbing in there so you can have a baby more comfortably. When we do an epidural steroid for that inflammation around a herniated disc, we put a little bit of numbing just to make it more comfortable, but you certainly walk out of the place and it's not to numb everything up, just to make it more comfortable. But it's the steroids that are put in the spine to reduce the inflammation and reduce your symptoms. And actually the disc herniation will resorb over a number of weeks or months, more or less. So there's a time frame. If you can tolerate conservative care and improve, the herniated disc can shrink. This is a study by a Swede, I believe, called Nakamsen. So the things to know here is that if you have lumbar disc pressures where if you're standing, say that's 1 or you could say 100, whereas if you lie down, the pressure is off those discs, so you're getting the pressure off the discs. Or you're bending forward or you're bending and lifting, look at it, it's more than double. Sitting with good posture is still 1.5 times almost. Slumpy posture, you're more than 1.5 times. Bending over and doing a little dumbbell sitting, it's terrible, almost 3 times. So if you have a disc problem, a disc herniation or a degenerative disc that hurts, that may or may not refer pain down the leg and give sciatica, usually if you're in these kind of postures, or that's part of the history, saying that I don't like bending, sitting bothers me, I like walking better, and I hate bending and lifting. And so that's some history, and the exercises can reflect what's good and what's bad. So these are sort of classic, we say McKenzie extension, where somebody with a herniated disc tends to feel a little bit better if they can extend, with the exception if you have a bad disc that's giving you stenosis. So even they're kind of in a pickle, they can't really bend forward and they can't bend too far back, and that's a tougher case. Here's a classic spinal stenosis. As people get older, we showed the picture of the spinal stenosis, where the nerves were being pinched in that little triangle. When you, oh, I'm sorry, Carrie, I got heavy on that again. So this is classic where spinal stenosis bothers people when they're in extension and walking, where they have the quote shopping cart sign. They lean forward on the cart, so you have some support, but you're bending your back, going into some flexion, so that you can get a little more mileage. So when we do exercises for the spinal stenosis, we tend to do the more flexions, which originally I think the Williams flexion exercises, where knee to chest, etc. They tend to relieve, and it feels better for people with stenosis. So when we have therapy prescribed, we're looking at the movement patterns and exercises that tend to alleviate or improve symptoms. And the ones that tend to aggravate, we stay away from those exercises. Now, here's the epidural injection that I'm talking about. Transforaminal, meaning the needle is coming in and it's going right where that exit zone or that foramen. So this is the L5 nerve. And this is probably for a L4-5 disc herniation that will be pinching the L5 nerve here rather than in this exit zone. So this is what this is. When you do an x-ray of the nerves, you don't see the nerves. Oh, one more. Well, actually, I won't say one more. I'll probably screw up again. So, but when we put the x-ray dye here, we outline the sheath around the nerve. We're not injecting in the nerve, and it's going in the nerve sheath and into the epidural space with a small amount, about a cc, and it'll continue to flow. After I document this, I put the lidocaine to make it more comfortable, about a cc, and then I put about a little over a cc or cc and a half of the cortisone, so that'll be flowing right where that disc is right here. So the idea is to reduce the inflammation of that disc herniation to allow increased function, decreased pain, and give time to heal, that resorption of the disc. This is just another type of epidural which is off-center, called interlaminar, and showing this is the contrast fluid. So we know where epidural, there's epidural fat, so the little globules. It looks like a frappuccino. It's not a smooth pattern like if you do a spinal. And that's, we know it's the right spot, and we put our cortisone in. So I was talking about resorption or shrinking of a disc herniation. So disc herniation can regress or resorb or shrink in a big number of patients. So the best treatment, therefore, is a balance between conservative care, where you might have medicine, physical therapy, good body mechanics, and doing the right thing for your back, not bending and twisting the right way, etc. So as long as you're able to function and you're not having a severe neurologic dysfunction like weakness, you can continue on the conservative approach, as long as the pain is not intractable, etc. So actually the overall incidence in this particular study is about 2/3 that the lumbar disc herniation will reabsorb or resorb. So conservative treatment really is the first choice of treatment for LDH, lumbar disc herniation. Sorry about that acronym. So here's a big disc protrusion right here. And in fact, the cross-sectional, this is causing stenosis, very little space. And they didn't really outline the time frame, whereas reading this, but later on, probably a number of months, it's resorbed. It's still herniated, but it's smaller. Much more room in the central canal compared to this little area, that white, the central canal. So that the symptoms can basically go away. So now if conservative care does not work, we would look at the conservative care for nerve impingement that we've been talking about. It's causing sciatica, pinched nerve in the back, causing the buttock and leg pain. It may cause the radiculopathy, the dysfunction with the sensation, strength, reflex, etc. So the surgery is primarily intended to decompress the nerve pinch symptoms. The relief of the actual back pain is less predictable for that kind of a decompression. And I might note that Dr. Mike Glover and Eamon Mahoney are specialist spine surgeons for Northern Arizona Orthopaedics in the different spots of where I am based out in Prescott, as well as Flagstaff and outreach areas. So some of the fancy procedures they can do, they can have minimally invasive. Invasive means so that's smaller surgical access. You can do it through an endoscope, spine surgery. Microtubule, so they can decompress and open up the area with tubules, basically to make it smaller and less of an incision. Now, the typical laminectomy is the lamina is opening up the bone in bone spurs, and discectomy taking out the disc. And if it would be unstable in certain cases, then you would fuse it. In this case, called the Spondylolisthesis, which I mentioned back in the anatomy slides, where it's slipped forward. There can be a kink along here that you might have to decompress, and then you might have to fuse it. There's actually a defect here of the bone called a pars interarticularis or pars defect, whereas this is just degenerative. The ligaments get lax. The next slide actually shows the pars isthmic is a fancy term, where that's the defect, or degenerative. There's no defect, it just has loose ligaments from the degeneration. But this may need surgical fusion. This is right there. The anterior and the posterior fusions, so it doesn't keep slipping, or they can bring it back. And that would be failed conservative therapy for the spondylolisthesis, the slip. So we're talking about the conservative for either the spondylolisthesis and the neural compression, the pinched nerve causing sciatica. But for the referred pain, the other structures that aren't actually pinched nerves, of course, the medication, the posture mechanics, same kind of conservative care, but depending on what condition is how you do the therapy. Let's see. There we are. Oh, there we are. Here we are. Gosh, I'm a bad lefty on this thing. So the non-neural impingement. Talked earlier with that, the facet joints. They're the little joints in the back, like the back of the trike wheels. You can inject the joint, but the research actually shows that the nerve right by the joints called the medial branches that we test block, and then you do a radio frequency, a heat lesioning of that. That's the way to treat those joints. And that may cause only back pain, and it might cause pain down the butt and leg like we showed you. The sacroiliac joint can inject. Radio frequency is a little more experimental. Hip joint is not the cause of sciatica, but we can inject that. The bursa can cause pain at the side of the hip or down the side of the leg, and we can inject that. And muscle and ligaments. The ones in the buttocks can cause pain down the legs. We can look at trigger point injections. Trigger points are the tender point, and we can work with the injections and therapy to help that. Questions? So chiropractic care can help with this, with the spine. They may treat what's called, they tend to call it subluxations, which is a little different than subluxations that we would call with a radiologic. But it can be segmental dysfunctions. Different segments of the spine can not move as smoothly, and the manipulation that chiropractors can do can help the spine segment pain. There is some of the chiropractors do have the traction units or the decompression, but the literature is a little bit mixed on that. So sometimes there's chiropractors have some exercise therapists in their groups, but they're typically not physical therapists that are licensed physical therapists with more training. So, I mean, there's some overlap. I think sometimes if I would refer to a chiropractor, it might be if I've work through the conservative care that's typical in our physical therapists and so forth. And certain areas of the spine that there's nothing surgically to do, or the mid-back's a little tougher to treat. I've referred to some chiropractors and certainly welcome working together back and forth if they see patients with herniated disc where we can help with medicines or even some injections, and they can work with the exercises and manipulations that really overlap some of the things we do. So a very common source of neuropathy is diabetic neuropathy. Diabetes, unfortunately, is getting more common all the time, and that's a very common cause of neuropathy. So neuropathy means nerve, and pathy is for pathology or disease, so it's nerve disease. And usually the longest segment of the nerve away from the body is the longest part away from the spine is actually the tips of your toes. And so it's a disease, and typically the circulation isn't good in diabetes, so then that affects the circulation to the nerves, and then that's a common cause. The next common cause is probably what we call idiopathic, meaning we joke, we say, well, we're idiots, we don't know, but actually it's just in older folks that there is an idiopathic or really an unknown cause of neuropathy. That's a very common. That when people are older, you can get a little numbness of the foot. We can do, and I commonly do the nerve testing to see if they actually have a pattern of neuropathy. And there can be tests. There can be nutritional neuropathies like vitamin or B12, et cetera. That tests can be run. There's neuropathies from lead exposure and heavy metals. Certainly if people have some kind of toxic exposure history, which hopefully with workplaces are better these days, we're not seeing too much of that. But the original question was, in older folks, how do you get neuropathy? Most common diabetes, or really next common, is idiopathic. It just kind of happens. Well, we want to look at it. We take a good history, like what happened. We do a good exam. We see, is it actually causing what distribution? Does it actually follow a nerve or not? Is there weakness or reflex changes? Do we work with a conservative care? As long as there's not severe weakness, we will probably work with conservative care and medicines before getting the scan. And certainly we would get an MRI scan, if that would correlate with one of the nerves, that would be a pretty good indication that that's the problem, as you have the imaging correlate with your patient presentation in the physical exam. And the next was a sacroiliac joint. There's certain sacroiliac stressing tests on exam that are suggestive of sacroiliac but aren't perfect. There's the distribution, where you got that little spot where we showed on there, the focus of the sacroiliac pain and the tenderness. But frankly, there's a little bump that people have in their back there that's almost always tender. When you have chronic back pain, the buttocks becomes tender. So anything in your low back, it seems like your gluteus are almost always tender. So that was a little harder to tell. So certain tests, pelvic stressing tests, the Faber flexion, abduction, external rotation testing. There's a few other pelvic, exam tests. And and then usually imaging is not that good. Most times when you have sacroiliac problems, it's not because you have arthritis. Certainly there are arthropathies and arthritis of joints with rheumatologic disease that cause sacroiliac arthritis. Most of the time it's more ligament pain. If you have a pregnant woman, that when you're having the baby and you have relaxin, so it relaxes the pelvis, that's a common cause of relaxing the pelvis too much. And pregnant women, where young women in 20s and 30s most commonly have sacroiliac pain, is reasonably common. Spinal stimulation, and that's another one that's more palliative. For example, if you would have spinal stenosis, the one, remember, where the canal is that big, but with a stenosis, it might be that little triangle because it's got the disc bulge and the two facets that's gone down. So if you're trying the conservative care, depending on the spinal stenosis, it might be mild, it might be moderate, it might be severe. The degree of symptoms you might actually have, it's really variable. It's just the arthritis and what you see on pictures, again, it won't all correlate. But again, if you have very severe stenosis, there's more chances that you're not great. So you probably wouldn't want to be doing a spinal cord stimulator for spinal stenosis, because you probably would want it fixed, right? You could fix it. But let's say that you have the spinal cord stimulators were originally caused that if you would have the decompression done in your spine, and so you'd have maybe some scar tissue and there's nothing more to decompress. Sometimes a nerve is pinched for a certain period of time, or is pinched badly enough that even with surgery and decompression, it's just sort of a hurt nerve. It's just always has scar tissue and pain. So spinal cord stimulators were, I think, kind of initially good for that sort of thing. And I think some peripheral neuropathy pain too. I'm not personally putting in spinal cord stimulators, but knowing that some of the indications. Some of the newer stimulators are actually better for what we call axial back pain, the back pain itself. But typically stimulators, I look at as the palliation, that really everything to fix it has been done. I wouldn't think of putting a foreign body in your back when you have stenosis, when really you need to fix it. Decompress it. Don't put the stimulator in and have a foreign body and a Band-Aid, do a decompression. But if you've already done everything, stimulator can be helpful. Well, treatments for that. So if it's idiopathic and it's not diabetic, for diabetic, I guess you try to control as best you can. But idiopathic, there's not a cause. You're not taking the B vitamins. But there's certainly palliative treatments. Again, palliative meaning you do things to help the symptoms. There's a medicine called gabapentin. The other name is Neurontin. That can be very helpful for nerve pain in many patients. It can cause some drowsiness or a little dizziness. Some people take a little smidgen of it and can tolerate only that. Some people take a big dose. For example, maybe 100 milligrams at night is all somebody can tolerate, but it helps them sleep a bit. But some other people might be taking 800 3 times a day. So it's variable. The other medicine that it's still, it's not generic yet, is Lyrica or pregabalin. That's another one that can be helpful. The old drugs that were for nerve pain were like anti-seizure medicines. Actually, gabapentin was an anti-seizure, is an anti-seizure medicine too, and it has worked for bipolar depression, but it's not, they don't use it all that much for that. I think it's more, people use it more often for the nerve pains. Some of the more heavily side effect medicines, the old medicines for seizures, were used for nerve pain too. Well, that's a good question. I tell people that, it really, I think sideline is probably better, but I mean, the back is good too. The one thing though, if you have spinal stenosis, it depends if you have a condition. If you have spinal stenosis in anything where you straighten out your spine, standing is not too good. Usually if you're sleeping straight on your back, and especially if you sleep on try to sleep on your belly and you're arching your back because they'd hate that. They don't want to do that. So you'd be on your side or even curl up in the fetal position to open up the canal. I think in general, I think it's, assuming your spine is not hurting specifically where you have a condition where you're hurting at the time, I think the back or the side are probably the better ways. But if you find your way in the middle of your sleep, going from one to the other, or you just can't tolerate one or the other, you have a shoulder problem, you can't sleep on your side. Certainly on your side, you want to have a good pillow so you're supporting your neck and so forth. I think just whatever really is best, works best for you.